So next up we have Dr. Janice Taub, who is actually really an international expert in terms of the development of pathological response assessments. She's a dermatopathologist at Hopkins who's an immunopathologist and has read all of the Checkmate 816 and 77T trial results. So thank you, Dr. Taub, for coming today.
Thanks, John. Thanks also, Pierre-Olivier. This is quite an honor to be here.
Maybe take the, I feel like the sound is stronger.
Slides.
Can we get the slides up for Dr. Taub, please?
That's not the one.
Yeah, it's not that.
Should be TAUBE is the file. There you go, that's looking good. Okay. Why the irPRC assessment should be our standard of care. These are my disclosures. All right, so what are our goals for pathologic response assessment when you're developing a scoring system? We want it to be a surrogate for long-term survival. We do want it to be a system that pathologists can and will use reproducibly. And ideally, if possible, you want to have a pan-tumor system. A couple of details about this. So when you think about surrogate endpoints, those that support accelerated FDA approval, the FDA requires an endpoint is reasonably likely to predict clinical benefit, that they associate with outcome, and then this phrasing is a little funny, so hang with me, this is how it's written, that they manifest the overall treatment effect on clinical outcome. And what's meant by that is if you have, a small change in your analyte, you have a small change in survival, you have a large change in your analyte, you see a large change in survival. So here we're getting at the idea of a continuous variable. Right? You can also think about path response as the analog to how we use RECIST right now in the advanced disease setting. And a number of people have mentioned the fact that in neoadjuvant setting, RECIST doesn't perform very well, and we know that path response does. But in keeping with the pan-tumor theme, if you think about RECIST, you use RECIST in lung, we also use RECIST in melanoma. You use the same scoring system whether you're looking at a primary tumor, a lymph node, or advanced metastatic disease. We're not deriving new scoring systems for each of these different scenarios. And so this is a quote from the paper that implemented RECIST. We believe that the adoption of standard criteria of response should be given high priority. Uniform criteria should not be chosen on the basis of popular opinion, or I would argue, based on a individual society promulgation, not based on published data, but because they meet standards of reliability and validity. Thus, the criteria must be reproducible and should correlate with other measures of patient benefit, again, getting at the quantity and quality of survival. So how did we get here? So when we first started, we were looking at Patrick Ford's study, anti-PD-1 alone, in the neoadjuvant setting, patients treated with lung, and we published it in 2018. Shortly thereafter, we looked at more than 500 specimens from more than 10 different tumor types, and we were able to identify common features of regression. And we used this to publish a proposal for pan-tumor criteria for scoring immunotherapy. But around the same time, we were also looking at other therapies. And Pierre actually made our point for us, which is that this tumor regression, the neovascularization and fibrosis, actually is not specific to immunotherapy and is in fact something that you see across different therapies as a part of the wound healing of tumor regression. And so here we are at 2024, where we have a pan-tumor, pan-therapy approach to assessing pathologic response. And so it's now been implemented, and this is just a selection of papers: colon, esophageal, Merkel cell, head and neck, cutaneous squame, gastroesophageal, amongst others, lung for sure. And then across numerous treatment regimens, so immunotherapy, chemotherapy, targeted therapy, immunoradiotherapy, and many combinations thereof. So importantly, how do these features associate with patient outcomes? This is from the melanoma group. This is a meta-analysis showing pathological response and survival with neoadjuvant therapy. The top two lines are path CR and near path CR. The intermediate line in green is 50% or less, a so-called partial pathologic response, and then those with greater than 50% doing the worst. So a nice dose response curve. I think it's really important to underscore here that these patients were treated not just with immunotherapy, but this is also representing patients that were treated with targeted therapy. In the melanoma setting, of course, this is BRAF and MEK targeted therapy. Patients with Merkel cell scored using the same scoring system, path CR and non-path CR. Merkel cell cancer is rare, and so we didn't have enough patients on the trial to be able to stratify by different levels of residual viable tumor, but you can see this nice separation between path CR and non-path CR. And then we've seen the graph on the left a number of times at the conference. This is from 816, again showing that nice dose response in terms of residual viable tumor and EFS at 2 years. But while we've seen the KM curve and we've heard the term continuous, we haven't looked at the ROC curve yet, and that's what's shown on the right. And this really shows that requisite that the quantitative amount of what's left behind correlates with how the patient does, long-term and over time. Again, comment was made about regression is hard to look at. I will tell you, when I stage melanomas, I'm a dermatopathologist in clinical practice, actually. Regression is one of the things that we tick off, and we tick it off fast. You look at it, and you see it, and you know that it's there. It's one of 12 parameters that we stage. And so pathologists can reliably recognize regression once they're trained. It just hasn't been a part of the lung community until this point. And so what we're showing on the left is regression as it's looked at from pre-treatment to post-treatment and how it increases, showing that we are identifying and the markers that we're scoring manifest that treatment effect. It is simple, and at the same time, it's based on data that's been correlated with regression. And then shown on the right is an ROC curve, this time not looking at percent residual viable tumor, but looking for regression. And it shows similar performance, again showing that the constellation of features that we're scoring have biologic significance and that pathologists can do this. And so is this a system that pathologists can and will use? We started in immunotherapy, like I said, and we were most grateful to partner with SITC for a pan-tumor harmonization effort for standardized data collection. And so this is now coming to a close. The study was composed of 12 different tumor types. We had 14 pathologists from around the world participating in this, including Pierre, as he had mentioned before. We looked at 42 specimens, a total of 362 slides. The patients received a variety of treatments: immune checkpoint blockade, chemotherapy, targeted therapy, and combinations. And the interclass correlation coefficient amongst pathologists was excellent. And so I think it's important here to say that these coefficients were tested not just at the level of no tumor or 10% at MPR, but at 10% intervals, right? So as we look beyond path CR, are we going to be able to score this reliably? And so the ICCs for those overall is 0.86. If you look in the primary tumors, it was 0.85. Scoring lymph nodes also robust at 0.87. And as we really start thinking far ahead for tissue-sparing approaches, whether it's head and neck cancer or bladder, if you want to take a biopsy rather than doing a complete resection, we are also able to score that reliably as well, 0.93. within this larger group of mixed tumors for those that had numerous so that we could do subset analysis. You can see here non-small cell lung carcinoma had an ICC of 0.86. All the others were around 0.8 or above as well. So pathologists think that they can do this as well. So this is a CME course actually that Dr. Cottrell taught at USCAP, which is our annual pathology meeting in 2023. So there were over 200 pathologists who took this pre-test poll that said that they believed that they could readily identify these features of regression and that we could support a pan-tumor scoring system. So 68% coming in said that they could do it, and after one educational session, all of the pathologists felt comfortable coming out, thinking that they were able to do this. I will also say that we have a number of modules through SITC that are about to be published for training pathologists in this. So the question that I get, how does irPRC compare to ISLAC scoring? As was noted previously, PathCR is PathCR. Does not matter which system you use. 0 equals 0. And I've gotten a lot of questions about this. It was noted in terms of the grossing. The grossing is incredibly important. But for Checkmate 816 and 77T, specimens that were less than or equal to the 3 cm that is recommended also by ISLAC were completely submitted in their entirety. For those who are taking pictures, this detail is published as a part of the Nature Medicine paper by Deutsch et al. Every slide that was generated was used for assessing path response. So in 816, that was an average of 35 slides per case. So we are well above the 20 that was recommended by ISLAC and Dr. Weisfert in terms of reliability. So some sort of sampling error in no way is responsible for the differences observed with PathCR. If you look at PathCR as predictive for the hazard ratio of EFS, those that are scored with irPRC are shown in green, and those with the ISLAC criteria are shown in blue. And you can see that these are effectively equivalent, no difference there. Okay, so then when we really get into the differences, there certainly was differences in calculation. A lot of it has to do with how you handle the intratumoral stroma. It's really inside baseball, and we estimate that the differences between the scoring systems probably account for maybe 5% of cases. And so this is mostly what it would mean to the non-pathologists in the room. And so with that, like the guiding principle is like, in theory, could you have a more elaborate, more detailed, or even more simple disease-specific approach to scoring? If so, it would have to be clearly more superior with regard to predicting survival outcomes to really outweigh the benefits of having an efficient and robust and effective pan-tumor system for RVT assessment. And so here up above, in terms of what's going to support our surrogate endpoint, we meet everything with the pan-tumor criteria. Studies on ISLAC have only shown data for PathCR and MPR, and they have not shown anything showing that there's manifest overall treatment effects on clinical outcome. Pathologists are definitely able to do both reproducibly, but they prefer a system for routine practice, especially outside of academic thoracic pathologists, where they can use the same system across multiple tumor types. And obviously, by definition, the pan-tumor system is generalizable to other tumor types, while ISLAC is not. So when people ask me, as they're planning a study, what should we use? Should we use the ISLAC criteria? This is my answer. So a couple of specific acknowledgements. Julie Stein-Deutsch, who has also run the 816 and 77T central pathology reviews with me. Tricia Cottrell, who is here. Pierre Olivier, who helped contribute to the great data showing how wonderful pan-tumor is. And I also really want to specifically thank BMS, and I know that there's a table and a number of my collaborators that are here. As a company, Dave Felquate and Robin were absolutely wonderful in sort of investing early in this idea of pan-tumor and developing and supporting it, and because that, I think we're well poised now to have this pan-tumor system. Thank you.